After a very beautiful inauguration there, musical inauguration, later it will follow on. So we begin the day. There is some technical glitch regarding presentation of the faculty CV, but Dr. Abhisek Raha would require no introduction, already being introduced by Priyanka. So he is a consultant physician diabetologist and attached to presently working as the divisional medical officer at Lamning Divisional Railway Hospital. And he has taken part, he has got many accolades and he has taken part in a number of conferences. I'm not going into the details because the topic is very interesting. And we as diabetologists, we look after the therapeutics and we have little time for talking about the main gold standard, that is the medical nutrition therapy. Previously, we just talked about diet, and it was only diet, but MNT encompasses, right, the diagnosis, what it is a customized, personalized diet. Not only it does diagnose the deficit or whatever is required, there is therapeutics as well as counseling. So I won't waste time. In details, it will be discussed by our reverend speaker. Thank you.
Hello. A very good morning to one and all. Thanks to the organizers, Bhattacharya sir, Mridul Bera sir, Joytidi for this opportunity. So today I'm going to talk about medical nutrition therapy, which is an upcoming topic, I feel, and the most neglected one. I feel this is the least talked about in a diabetic clinic, but I feel that in today's scenario, this should take a real upper hand to get in acquaintance with the medical management that we are referring to in certain chronic diseases. So medical nutrition therapy is a type of healthcare services that involves the use of evidence-based nutritional intervention to treat and manage various medical conditions. It is a comprehensive approach that includes the assessment, diagnosis, and treatment of nutritional problem and associated health conditions. It's a form of treatment of a disease or a condition through the modification of nutrient or the whole food intake. There is evidence-based application of nutrition care process provided by diabetologist, physician, nutritionist, or a diabetes educator even. So the use of specific nutrition services to treat chronic condition under the supervision of a registered dietitian or a medical professional. The importance is it plays a crucial role in managing conditions like diabetes, cardiovascular disease, obesity, kidney disease through personalized nutrition plans. MNT integrates the medical and nutritional expertise to provide and improve patients' outcome, forming a vital part of modern healthcare strategies. The objectives of MNTs are supporting overall health and well-being, preventing diseases, achieving and maintaining a healthy weight, and managing chronic medical conditions. The key principles of medical nutritional therapy includes the individualized dietary plans. Each patient's nutrition plan is tailored to their specific health needs, preferences, and medical condition, ensuring optimal outcomes. The evidence-based practice is grounded in scientific research with continuous updates based on the latest clinical findings and nutritional studies. And it collaborates with medical treatment to enhance overall patient care, emphasizing the role of diet in disease prevention and management. So for specific conditions like diabetes management, carbohydrate regulation is crucial for maintaining blood glucose level, with MNT offering a structured plan to manage glycemic control. In chronic kidney disease, the dietary intervention focuses on controlling protein, sodium, and potassium intake to reduce kidney burden and thus prevent progression of CKD. In cardiovascular diseases, the heart-healthy diets low in saturated fat and sodium are prescribed to reduce lipid levels and improve overall heart functions. Now coming to transitions in India, there is a dramatic transition to urbanization, an unhealthy modern diet, and a low activity pattern. Replacement of traditional Indian meals and recipes that includes legumes, coarse cereals, whole grain fruits and vegetables with modern foods comprising of refined carbohydrates, added sugar, and high intake of fats. There is exponential expansion of fast food establishments and supermarkets allowing easy access to Western foods. Excessive consumption of sugar and jaggery-laden sweets that have significant cultural and religious relevance as well. So the techniques used in MNTs are, first of all, there is nutritional counseling, there is dietary changes, supplementation, medical nutritional products, and monitoring and follow-up is a very important part of MNT. So the process of MNT delivery includes the nutritional assessment, evaluating dietary intake, health status, and lab values to understand the patient's current nutritional needs. Diagnosis and intervention includes developing a nutritional diagnosis and creating intervention strategies such as dietary modification or supplementation, and continuous monitoring and evaluation of the whole process of MNT is a very crucial part so that the patient can follow it up. Coming to research data, in MNT lowers HbA1c by 1%, 1 to 2% in type 2 diabetes patient and 1% in type 1 diabetes patient, showing a significant reduction in the blood glucose level. In cardiovascular disease, it improves the lipid profile, reducing LDL cholesterol and overall cardiovascular risk through personalized dietary interventions. And MNT reduces health cost by lowering the need for hospitalization and expensive interventions. Coming to the expected outcomes, as I have already told, there is reduction of 1% of HbA1c in type 1 diabetes and approximately 2% of HbA1c reduction in type 2 diabetic patients. There is 1% reduction in type 2 diabetes patient of 4 years duration. LDL cholesterol also reduces by 15 to 25 milligram per dl in 3 to 6 months. In type 1 diabetic patients, the insulin therapy should be integrated into an individual's dietary and physical activity pattern. Individuals using rapid-acting insulin by injection or an insulin pump should adjust the meal and snack insulin doses based on their carbohydrate content of the meal or snacks. For individuals using fixed dietary insulin doses, carbohydrate intake on a day-to-day basis should be kept consistent with respect to time and amount. For planned exercises, insulin doses can be adjusted, but for unplanned exercises, extra carbohydrate may be needed. Implement lifestyle changes that reduces intake of energy, saturated and trans fat, cholesterol and sodium, and increase physical activity in order to improve the glycemia, dyslipidemia, and blood pressure. Plasma glucose monitoring can be used to determine whether adjustment to food and meal will be sufficient to achieve blood glucose levels or if the medications needed to be combined with MNT. Dietary pattern that includes carbohydrates from fruit, vegetables, whole grains, legumes, and low-fat milk is encouraged for good health. Monitoring carbohydrate, whether by carbohydrate counting, exchange, or estimation, remains a key strategy in achieving glycemic control. So, carbohydrate counting is a very upcoming topic and is a very new concept in the town. So the thing is that we have come up with, we are using technology right, left, and center. So there are various apps which helps us in carbohydrate counting and helps in the process of medical nutritional therapy. Sucrose containing foods can be substituted for other carbohydrates in the meal plan, or if the added meal plan covered with insulin or other glucose lowering medications, care should be taken to avoid excess energy intake. The use of glycemic index and glycemic load may provide a modest additional benefits over that observed when total carbohydrate is considered alone. So glycemic index is another upcoming and burning topic. So glycemic index measures how quickly a carbohydrate containing food raises blood sugar level. It ranks food on a scale of 0 to 100 with higher values indicating faster digestion and absorption. It is introduced in early 1980s by Dr. David Jenkins at the University of Toronto. It was developed to help people with diabetes better manage their blood sugars. It helps in choosing food that manages blood sugar level effectively, can help improve long-term outcome, particularly for diabetics. So the blood glucose response of a given food compared to an equal amount of carbohydrate standard, typically glucose or white bread, is measured. So GI basically measures how quickly carbohydrate containing food raise blood glucose levels. Foods are ranked on a scale of 0 to 100. So high GI foods, low GI foods less than 55 results in slower glucose absorption, while high GI foods more than 70, it causes spikes in the blood glucose levels. Low GI diet helps manage blood glucose, reduce the risk of type 2 diabetes, and improve heart health. Glycemic index is influenced by various factors: the starch structures, the fiber content, the cooking methods, degree of processing, absence and presence of fat, whether it is eaten in the context of a meal. A given food can elicit a very highly variable response. So low GI food, as I've already told, it digests slowly, causing a gradual increase in blood glucose level, where high GI food digests quickly, leading to a sharp spike in the blood glucose. High GI foods trigger a rapid insulin response, whereas a low GI food leads to a more controlled insulin release, reducing the risk of insulin resistance. Low GI foods tends to keep you fuller for longer, which helps in controlling hunger and maintaining weight as well. So low GI food is in the range of 0 to 55, whereas the medium GI food is 56 to 69, and high GI food is the foods which have a glycemic index of more than 70. Low GI food helps in managing weight by keeping you fuller longer, reduced risk of overeating and obesity. Beneficial for people with diabetes, as it reduces rapid blood sugar spikes, can lower the risk of insulin resistance. Obviously, lower the risk of heart disease as well by improving cholesterol level, decreasing inflammation, and promotes better cardiovascular health. So glycemic index we have already talked about. Now coming to glycemic load, it takes into account both the quality and quantity of carbs, gives a more accurate measure of how food impacts blood glucose levels. GI only talks about the speed, whereas glycemic load includes carb content. Glycemic load is considered as a more practical tool for meal planning. Glycemic load is calculated by multiplying the glycemic index by the amount of carbohydrate in a serving divided by 100. Unlike glycemic index, glycemic load considers portion sizes, making it more practical for meal planning for blood glucose management. Glycemic load offers a more accurate prediction of how much a food will rise blood sugar based on the serving size, making it more useful than GI alone. By considering the carbohydrate content in a typical portion size, glycemic load helps to manage real-world eating habits. Glycemic load is more practical for managing diabetics and also to predict the spikes. This is a chart which mentions about the glycemic load and glycemic indexes of few foods. As I have already told, that low GI food should be incorporated and high GI food should be avoided. A few practical tips for using the glycemic index: choose whole grains, opts for oat, brown rice, barley over refined grains. These food have a lower GI and offer more nutrients. Pair carbs with proteins. Eating carbs with protein or high or healthy fat lowers GI. This helps in controlling blood sugar spikes. And we should definitely limit the usage of high GI foods, which includes sugary drinks, snacks, sodas, white breads, etc. So here I would like to stress upon one point which I haven't mentioned in the slides. Recently, one of my paper has been published in International Diabetes Journal, where we have studied and did a small research on 80 individuals, where all are type 2 diabetic patients who are on metformin and glimepiride, the highest amount of doses, but still their glycemic control was not up to the mark. So we followed them up for 4 months, and all we did is that we have asked, and all of them were railway men actually, railway employees. So basically what we have done, we have asked them to take 20 milligram of almonds 30 minutes prior to their lunch and dinner. And we asked them to continue it for 3 months. We followed them up for a period of 3 months on a fortnightly basis. And drastically we have seen that though the patients who were on metformin 1000 milligram BD and glimepiride 2 milligram BD and were uncontrolled on their fasting and PP, their postprandial blood glucose levels, it changes by an average of around 40 to 45 milligram per DL after the end of a 3-month study period. And we are promoting, after that we are promoting these things, those who can afford 20 grams of almonds 30 minutes before. Actually the whole sense of this research was that there have been many papers which suggested that if we take a protein containing diet or protein in moderations 30 minutes to 45 minutes before our major meal, what it does that it improves our satiety, it reduces the intake of food in our main meal, and overall diet rich in protein contents will definitely have a low GI spikes, and thus it will help in maintaining the blood glucose level. We have practically done that, and we have found a very good result. And those who can afford, we are promoting those patients to have almonds in moderation amounts before their major meal. Talking about sweetener and diabetes, sugar, alcohols, and non-nutritive sweeteners are safe when consumed within the daily intake level established by FDA. Nutritive sweeteners has lower GI than sucrose or starch. Large amount may negatively affect the lipids. No advantage to substituting it for sucrose. Now the non-caloric sweeteners which we are using day in and day out, and the patients are also using it. Even the patient in the pre-diabetic range are more concerned of using these low-calorie or non-nutritive sweeteners. But although we are promoting non-nutritive sweeteners or this sugar-free and all these things, but recent studies have found that patients on these sweeteners who are pre-diabetic, but they are taking these non-nutritive sweeteners, have a more tendency or they progress to their diabetic state earlier compared to those who are not using anything, who are taking sugarless things, sugarless tea, coffees. To those who are using these non-nutritive sweeteners, they are progressing from pre-diabetic to diabetic in a more rapid period of time or more quickly rather than those who are avoiding sugar as a whole. Protein and diabetes, I have already told, insufficient evidence to suggest that usual protein intake, 15 to 20% of energy should be modified. In individuals with type 2 diabetes, ingested protein can increase insulin response without increasing the plasma glucose concentration. Therefore, protein should not be used to treat acute or prevent nighttime hypoglycemia. So, high protein diets are not recommended as a method for weight loss at this time. The long-term effects of protein intake, more than 20% of calories on diabetes management and its complications are unknown. Although such diet may produce short-term weight loss and improve glycemia, it has not been established that these benefits. Yes, sir.
How many? How much time?
Sir?
It's long time. How many slides?
Sir, I've got 8 more slides.
Okay. Yeah. Carry on.
So, the aim of medical nutrition therapy, the preventing and slowing the rate of development of diabetes complication, achieving nutrition-related goals require the involvement of protein with the person with diabetes in the decision-making process. MNT is important in preventing diabetes and managing existing diabetes. So, this is a RSSDI chart where they have mentioned about the typical intake of food which we should follow. We should limit the carbohydrate intake to 50 to 60% of total calorie intake. Food with lower glycemic index and glycemic load should be preferred. Fiber intake should be 25 to 40 gram per day. The fat content should be 30%. Oil rotation is recommended. Food with high saturated fat should be avoided. Saturated fat intake should be less than 10%. And protein, we should be 15 to 20% of the total calorie intake. Consider other comorbidities like renal status and age of the patient. Limit red meat intake, preferred other source of proteins. Diet rich in fruits, leafy vegetables, nuts, fibers should be promoted. Pulses, legumes, unprocessed vegetables and low fat diet should be preferred. Salt consumption should be restricted to less than 5 grams. These are a few important topics. The brown rice should be preferred over white rice. Quality of protein intake depends on the age, sarcopenia and renal dysfunction of the patient. Reheating and refrying of cooking oil should be avoided. Extreme diet including low carbohydrate ketogenic diet must be planned and executed following consultation of physician and nutritionist and for a short period of time. Smoking cessation should be avoided. Fruit juices better avoided. Cereal and pulses can improve the protein quality and improve the satiety as well. All preserved food and processed food should be restricted. Recommended protein intake for diabetic nephropathy patients should be restricted to 0.6 gram per kg per day. Semi-solid food and fluids should be encouraged in sick days. Now, this is another important thing as we are moving towards the use of technology in the field of diabetes and other chronic diseases. So, certain apps are very much useful. I am promoting for my patient this MyFitnessPal app. This is a very, very good app. It helps to measure, actually, when we are buying certain foods, they have got a barcode. By using this app, we can just scan the barcode and get a details of how much calorie, how much protein, how much carbs it contains. And it helps in a better planning for this medical nutritional therapy. So coming to the last parts of my slides, which is intermittent fasting, it is a very debatable topic. Actually, this can go on for one session, just this intermittent fasting. Certain school of thoughts are that intermittent fasting helps dramatically in managing diabetes, but there are other scientific researches also which says that we should prevent intermittent fasting for a longer period of time. So as a whole, I would like to say that the take-home messages would be that MNT in diabetes is a very primary thing, but often overlooked. Concept about total caloric counting is important in diabetes, and we can take help of the apps which are available. With so much culinary diversity in India, it's difficult on how to rely on the cooking counting calorie. So knowledge regarding MNT in type 1 diabetes and other type of diabetes should be promoted. Exclusive MNT in type 2 diabetes without any form of OAJ needs to be discussed more. Exclusive MNT in GDM for more than 2 weeks can also be explored as well. So thank you very much.
It's open for questions. If any questions is there, you can ask. Is there any?
Any question from the audience?
If it is not there, then I should ask one question rather.
Please,
It's
sir.
very difficult for us rather to implement the MNT to the patients rather. They doesn't follow the things.
Exactly,
And
sir.
I think they doesn't know also. So what is your opinion? How we will be able to cross that barrier?
Sir, as I have already told that implementing MNT is the biggest challenge, and it is often overlooked. For example, when we are seeing a patient, we are more focused on prescribing medications or insulins or food habits. But MNT is a completely different scenario. For that, I feel other paramedical staff should come into play. And sir, exactly, that is what I'm telling. Actually, diabetes educator can play a big role. We have made a WhatsApp group as well for
Okay.
those whom we are promoting MNT, and we are getting them followed up on a periodical basis. And more than that, many people are now tech friendly. They can take care of these various apps which are available online. And the thing is that once patients start following it judiciously, and once they are coming up with better results in a shorter period of time, they themselves get promoted. But the thing is that who will ring the bell? That is the thing. Once we start MNT in
What
them,
is the percentage of that patients? I don't know.
Sir?
What is the percentage of that patients who will follow the MNT therapy?
sir, very less.
Very less. Okay.
Yeah. One comment or whatever I would tell you, congratulations for your presentation. I mean publication. Not all patients can afford, you told rightly, but on a very grassroots level, what I practice and what I find, I may not have publication, but that is very relevant. We tell our patients, the MNT part for, if we can't afford a diabetes educator, we just draw a plate and make it, just highlight that, that is one. And about the protein, improving the satiety, you tell your patients to begin the meal with some salads and 1 katori of dal. That is the easiest. And exactly what you found, exactly 30 to 40 pp fall will be there with the same meal, with the same medication. So this is a very practical approach. All of you can try because this is very relevant and we do it and we have found it. So maybe there are publications related to this. So you did with almond. Almond may not be palatable before lunch. So every meal you start with mixed salads, raita, and 1 katori dal, whole katori. Indians, particularly the Bengalis and in West Bengal, in the eastern part, the dal is very thin. They take dale jol. So it would be a thoke dal at least one time in a day. Barring renal patients also, they can also take dal, but the protein will be counted. So this is a very practical way of doing that, and I think that is very relevant.
Exactly, ma'am.
Any more question? One question, or should we wind up the session? And thanks to Dr. Raha.
Yeah, Dr. Raha, my question to you, that is more related question to the dietitian. You have just told that 30 minutes, that is amounts 30 minutes before main meals, that is 20 milligram amounts. And in what form it should be taken? It should be taken dry or soaked overnight?
Sir, the study that we have done, we have promoted the dry one only.
Okay.
But they say that if we take soaked almonds, it has got a better satiety and better sugar controlling ability compared to the dry ones.
Okay, I got your point.
We are running late.
Okay,
and
sir.
the dietitians are waiting for your questions. They are sitting in Hall C today. You can go there and you can have customized diet charts also if you need that. And any question, dietitians will be able to further foster the inputs. Thank you.
Okay, sir.
Thank you,
Thank
Dr.
you.
Raha.
Thank you, everyone.
Thank you so much, Speaker. I would like to request Dr. Abhisek Raha to please be there, and all the chairperson, please be there. And I would like to request Dr. Pamela Ghosh to please felicitate our speaker and chairperson on behalf of Howrah Town Diabetic Study Society. Thank you so much.